Broadcast is now starting. All attendees are in listen-only mode.
Hello, my name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders. I will be your organizer for this evening and would like to welcome you to our webinar on Freedom from Panic, Learn to Identify and Manage Panic and Anxiety in Adults. Thank you all for joining us. Before I have my colleague introduce the speaker for tonight, I'm going to cover some housekeeping items with you. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. You may send questions during the webinar. However, we will have Dr. Strohl answer the questions at the end of her presentation. We will get to as many queries as time allows. And in addition, tonight's presenter is available to take your questions on the Wednesday webinar blog, which is accessed from our homepage under the heading Programs. This blog will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. If you missed part of the presentation or would like to watch it again, an archived version will be posted to our website. We value your input, and in order to expand the webinar experience in the future, we need everyone to fill out the survey as you exit the webinar. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees, assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introduction of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Thanks, Kelly, and welcome everyone. Thank you for joining us tonight. Before I introduce our speaker, I would like to remind everyone that our second annual family picnic is planned for Sunday, August 25th from 11 to 3 at Johnson's Park in Piscataway, addressed Doctorate in Clinical Psychology at Rutgers University, Graduate School of Applied and Professional Psychology. She is a New Jersey licensed psychologist with an extensive background treating children, adolescents, college students, families, and adults living with a broad range of anxiety and OCD issues. Throughout her graduate training, she was a clinician at the Cognitive Behavior Clinic for Anxiety and Depression at Rutgers. Dr. Strohl is a clinical psychologist at the Stress and Anxiety Services, a group private practice in East Brunswick, New Jersey. She specializes in cognitive behavioral treatment of anxiety disorders with children, adolescents, and adults. She's also on the board of directors at the OCD Foundation of New Jersey. Dr. Strohl, we're delighted to have you back. And now, without further introduction, I'll turn tonight's presentation over to you.
Well, thank you so much, and it's a delight to be here tonight. Thank you, everyone, for tuning in to the webinar, and we'll begin right away. And so we're going to be talking tonight, Freedom from Panic, Learning to Identify and Manage Panic and Anxiety. Okay, hold on 1 minute. I just have to make sure the slides are advancing, and there we go. Okay, so let's start with this quote. It's a really excellent statement that begins our work tonight. And so CBT stands for Cognitive Behavioral Therapy, and we're going to be talking about panic in general. We'll be talking about anxiety tonight, and specifically panic disorder. And so the goal here is not to end anxiety. That's impossible. The goal is not to end panic attacks. That's beyond our control. The goal is to learn how to normalize and respond effectively to anxiety. If you learn to accept that panic attacks can happen, but are not to be feared, then you no longer have panic disorder. Although unpleasant, panic attacks are only a problem if they control your choices. Fortunately, panic can't control your choices. You are always in charge. Therefore, panic is not a problem. It's just temporary pain. And the graphic on the side that says pain is inevitable, suffering is optional. Really powerful words, and words that we'll talk about tonight in helping people really feel like this is one of the anxiety disorders, specifically panic disorder, that can be effectively treated and eliminated. Again, pain is inevitable, suffering is optional. So some of our goals for tonight's talk. We will differentiate panic attack symptoms in several of the common anxiety disorders. Later on, shortly tonight, I'll be talking about different anxiety disorders such as general anxiety disorder and obsessive compulsive disorder. We'll also learn how to assess and diagnose panic disorder in particular, and we'll discuss some of the hypotheses behind why someone has panic attacks, and we'll go into some treatment information. Cognitive behavioral therapy is the most evidence-based treatment for anxiety disorders, and we'll talk about the protocol specifically for the treatment of panic disorders with adults. I'll talk today about children and adolescents at different times to help point out some differences, although I really like to say the treatment is very similar, although we do specifically gear it towards this age group that we're working at. So whatever person is in front of me, I've worked with children with panic disorder all throughout to adulthood. And I'll talk about a little bit of the different attempts there. So let's start with what is panic disorder. We have our DSM-5, which is the Diagnostic and Statistical Manual. It's our diagnostic criteria that we use in psychology and helps things be more objective so everyone's on the same page with what they are. So to diagnose panic disorder, and again, I know that my audience is very varied. I'm talking right now to people who have panic and anxiety. I'm talking to family members who love people who have panic and anxiety. I know that there's some therapists who are listening to the webinar, as well as educators. So I'm going to make sure that this talk tonight really does cover an interest for everyone. While I am a clinical psychologist, I understand that my audience is very varied, and hopefully this, again, talk will really connect with everyone listening. And so the first criteria, again, to diagnose panic, just to give you a very clear understanding of what we're talking about tonight, is a recurrent and often unexpected panic attack. An anxiety disorder, specifically panic disorder, that's based primarily on the occurrence of panic attacks. And at least one panic attack is followed by a month or more of the person fearing that they will have more attacks. And so really a key differentiation here is that the person with panic disorder is afraid of the panic attacks itself. So they're not being triggered by some of the other fears that we'll talk about in a little, but they're specifically afraid of the panic attack itself. And so I wanted to make differentiation, what is panic versus anxiety. And so again, they share symptoms. We'll see in the next slides that the symptoms maybe look the same, but they differ in intensity, duration, and whether or not there is a trigger. Again, often with panic attacks, there is no trigger. The intensity is much more severe than with anxiety, and the duration is quite short. So a true panic attack occurs within 10 to 15 minutes in its entirety of the panic attack, where an anxiety or anxiety attack may last for hours and have a little bit less intensity and a much longer duration. And often there is a very specific trigger that's triggering the anxiety. And so here's a list of different panic symptoms. Again, to define a panic attack, it's an abrupt surge of intense fear or intense discomfort that reaches a panic within minutes, and during which time 4 or more of the following symptoms occur. And so here is a list. There's going to be a list of 13. And remember, to meet the criteria for a panic attack, a person only has to have 4 of the following that occur again in an intense, discrete time. And so here we go. Number 1, palpitations, pounding heart or accelerated heart rate, sweating, trembling, sensation-like state, and nothing feels real. Realization is a feeling of being detached from oneself. And so in that way, you're feeling like you almost have a balloon head and your head is floating above your body, kind of detached. And again, as we've been talking about tonight, these are symptoms that occur both within panic and anxiety, but we'll be focusing on the intense panic attack symptoms that come in more intensely. Fear of losing control or going crazy, the attacks. Often criteria for a disorder, you often have functional impairment and significant distress. We all can relate to having panic and anxiety. That is not a disorder. So I'll give you a nice example tonight as we're getting started with the webinar. I certainly had a moment of panic myself where I had the surge and my heart was racing. Sorry about that. Let's cut that off. And so I had a surge of anxiety because my headset wasn't working. And I knew my trigger, so it wasn't unexpected. I knew I was stressed because the volume wasn't working. I was able to make a quick change on the headset. The volume was working. My panic subsided. So again, it didn't create functional impairment. I was still able to function, and the distress was manageable. So in that way, it would not meet disorder criteria, but it's a symptom that everyone can relate to, which is really nice when you talk about it because, again, like we talked about in the first slide, anxiety is normal, a normal human adaptive emotion. Panic is not better explained by a medical condition in criteria C, and in criteria D, panic is not due to another psychological disorder. And so why do people panic? We have a few theories here. One is the suffocation alarm theory. So they're misappraising their bodily symptoms. So I can't get enough air. Something is wrong, danger. This is a direct quote from one of my clients who came in and said, I'm just, something is wrong. I can't breathe. I'm in danger. And what we like to call that is a catastrophic misinterpretation of a body response, a physiological response. And so it's a catastrophe in feeling, and it's a misinterpretation. We're missing out on it. The second one is something we call conditioning. Here we have a subconscious connection that was made with an environment or stimuli through conditioning that triggers a panic attack. So one example here is a person who's in a supermarket and they're shopping, they're not stressed, there's no specific trigger, but they have a panic attack. It's unexpected and out of the blue. And what do you think is going to happen next time they have to go to the grocery store? They're going to want to avoid it. They've now matched up conditioning, and it's something that they feel like they don't want to go back to because it feels like it's conditioning a trigger response. So it's something without treatment they would start avoiding, and certainly leads to functional impairment if they can't go food shopping. And so with the research there for their conditioning is back to Pavlov's dogs, if you're familiar with that. Basically in that research study, they had dogs who they showed some meat to, the dog salivated. Over time, they learned to pair that with a bell. So then all they had to do was show the meat and the bell, the dogs would salivate. And then over time, they removed the meat, and all they had to do was ring the bell, and the dogs would still salivate. Again, a nice example of conditioning. Here we have another explanation for why people panic. Here it's the fight or flight response. And here this is a physiological reaction that occurs in response to a perceived harmful event, attack, or threat to survival. So it's really important that the person in my office sees panic as normal and a biological process that's not dangerous. We definitely want to emphasize that it feels bad, it feels unpleasant. And so again, the message with panic is that it feels harmful, but it's actually your body's way of trying to be helpful. We go back to an example in the cave days. And so then a caveman or a cavewoman was walking around and a lion approached. And he had two choices. He could either fight the lion or she, or he could flight, get out of there. And so in that example, the body is adaptively charging the heart. So the heart starts racing. The paresthesis, the numbness in the extremities, is adaptive because all the blood is circling to the inner body. So if there is a lion attacking, then there's less blood loss. So again, I think this is so important to understand why this is happening. Why do we have this fight or flight response? That's really quite adaptive. However, it's a misfiring because in some examples, we're sitting in math class. This might be the college student who is sitting there and having a panic attack. Again, they're not worried about the math test or any of the math lesson, but their body is misfiring, sending out a harmful message when there is no danger. And our final slide, our final line reads, teaching acceptance of normal anxiety helps patients learn not to overreact to the symptoms that come before the panic. And our job in helping to learn to manage panic is to how to respond peacefully and effectively. So I always emphasize that our job is not to stop the panic, but react differently to the panic. And if you take a few things away from the talk tonight, that's one of them. Again, the job is not to stop the panic, but it's to react differently to the panic. Really nice point there. So here's some exclusion criteria for why a person would not meet criteria for panic disorder. So if your panic attack is triggered, then the panic attack is not unexpected. And there's a list there of different disorders that present, and we're going to jump into that now. The first one is social anxiety disorder. Here is an excessive and persistent fear that others are evaluating you. So a person goes into a social environment and they may have a panic attack, but clearly they could tell you that it's triggered because they're afraid that they're going to say something stupid or be judged negatively, and that's where the panic is coming from. And so here it's fear that you will do or say something that is embarrassing, will make you look bad, or make you the center of unwanted attention. As a result, the sufferer then actively avoids social situations where they feel like they'll be judged or evaluated in any negative way. And often the person could acknowledge their fear is overblown and that not everyone in the room is evaluating or judging them negatively, But again, a good example of where a panic attack may occur and not be panic disorder, but specifically in this example, a social anxiety disorder. The next one is general anxiety disorder. We call it GAD. And here it's characterized by excessive, uncontrollable, and often irrational worry about everyday things that is disproportionate to the actual source of worry. So here again, the person is catastrophizing. They're anticipating disaster or are overly concerned about everyday matters. This could be health, money, family or friend problems, work difficulties. So again, all the things we quote unquote may stress about in life. But the difference here is that this is constant and repetitive. And so if a person is having a panic attack, again, it's that discrete 10 to 15 minutes of intense surge of panic symptoms, then it's because they feel like their health is in danger, they're having problems with money or worried about death. So again, they're aware of their trigger. And often with GAD, they're getting that list of physical symptoms that we talked about. And again, a panic attack here can lead into an anxiety attack where for hours after they're just feeling the muscle aches, difficulty breathing, the sweating, the hot flashes, the muscle tension, all the things we talked about in the list earlier. And another disorder I like to cover, these again are all under the anxiety umbrella. And so another one that's important to understand is OCD, Obsessive Compulsive Disorder. Here the obsessions are recurrent or persistent thoughts, impulses, or images that are experienced at some time during the disturbance as very intrusive, very upsetting and distressing. They feel inappropriate, and they're marked with a lot of anxiety and distress. Often people will say that their OCD, their obsessions, are bizarre and intrusive. So they might have topics like sexuality and aggression, and they might have an obsession that they actually want to kill someone where they're not mad at anyone. And so it feels like a very intrusive and upsetting thought. And again, many of my clients have come in and had panic attacks based on some of their obsessive thinking. They've had thoughts that relate to contamination, and they feel like they're going to die because they've been contaminated based on an obsessive thought in their head. And the panic, again, is being triggered by the OCD here. The person will attempt to ignore or suppress these very distressing and upsetting thoughts, and they realize these thoughts are a product of their own mind and not product of sort of a psychotic disorder. And finally, compulsion. So remember, we talked about the obsessions. The obsessions increase our anxiety and they create marked distress. And the compulsions are repetitive behaviors such as hand washing, ordering, checking, or they could be mental acts such as praying that a person feels driven to perform to decrease the anxiety. And so the behaviors or mental acts are aimed at preventing or reducing distress and preventing a quote unquote dreaded event or situation. However, they're not connected in any realistic way. We call this magical thinking. So again, we understand the OCD loop and we understand the stressors that happen and why panic may occur within this disorder. But again, they're worried about the specific obsessions and then the rituals they need to complete, as opposed to being unexpected or untriggered. So let's talk a little more specifically now about the evidence-based treatment, CBT, cognitive behavioral therapy. So CBT tends to be a more structured therapy than traditional talk therapy. It involves specifically teaching skills or having patients practice these skills between sessions. So very hands-on therapy. It's very interactive, goal-oriented, and it's not just about venting to a supportive person, but rather learning strategies for dealing with emotions and life more effectively. Well, it's very important to establish rapport, which is relationship, and feel comfortable with your CBT therapist, but you also want to make sure your therapist is trained in the evidence-based treatments for all the different anxiety disorders we're talking about tonight. And again, CBT has been shown to be effective in random controlled trial research, which is why it has the most empirical validation. CBT is often referred to as an evidence-based treatment for anxiety and depression. And so there's several components of CBT. We have the evaluation part, which is something we'll go through where you kind of want to assess just what we did tonight. When a person comes to my office and they're saying, I'm having panic attacks, I'm going to do a thorough assessment and evaluation to understand what is the trigger. Is it unexpected? Are they actually afraid of their own body symptoms, such as panic disorder? Or is it more of the person that's afraid to give a speech like I'm doing tonight or go into a social situation, and then they might be more for social anxiety disorder? Psychoeducation, relaxation meditation, cognitive restructuring, exposure therapy, all critical parts of the CBT treatment. And so the first part that we start with under evaluation assessment is something that's called a self-monitoring form. And in CBT, we give a lot of handouts, and we help a person understand that, look, there's a list of these symptoms. And again, the body's trying to be helpful, not harmful. And if we could identify that other people have these panic attack symptoms, often understanding that is half the battle. And so we will spend a lot of time educating clients to help them understand their symptoms. And this form repeats itself, but the top form is a panic attack record. What they do is they put the date, the time it began and ended, if it was expected or unexpected, and they're going to rate the maximum fear that they felt during the panic attack from 1 to 10. They might write the triggers if there were any, or if it was out of the blue, and then they're going to circle the symptoms. So again, this is our list of the different panic attack symptoms. And again, to meet the criteria, they need 4, but sometimes in different panic attacks, they may have many of them, they may have several, they may have some of the same symptoms. It can really vary. I also let clients know that by self-monitoring, it's already an intervention because you become more aware of what's happening to your body and a little bit more objective of it, which can sometimes in the initial stages increase some of the panic, but often it does decrease it after a while because you become more of an objective observer of your panic attacks. And so some of the basic education that we spend some time helping people understand is if the panic is based in health anxiety, then we review the recent medical history. We recommend a checkup. I always want to do a medical rule out. So a person's come in and say, my heart is racing and I feel like I can't control it. I want to make sure they have a medical rule out. They've been seen by a cardiologist. And once that cardiologist says their heart is functioning well, then we know we could move forward with our panic protocol. But again, that's really important to do that, health check. And then after that, really limit the checking and safety behaviors because repetitive visits to the doctor would not be helpful. We want to explain the CBT protocol, and we want to explain that therapy focuses on skills. So we're going to talk about quote unquote homework. Although if I have a younger client in my office, I will not use the term homework because they will often not want to do it. We'll call it an experiment or something a little more hands-on, where adults don't mind the term homework often as much. But if I always ask my clients for their, word choice, what they want to use and what they feel more comfortable with. For our educators out there, as we're talking about this, it's important to know that, again, that you won't be doing the therapy, but the identification is key. And so if let's say in this case, it's a student, a child is coming in an office, so whether you're a teacher, a guidance counselor, a school psychologist, it's really important then that you're able to identify the symptoms and refer. And so maybe a school psychologist or a counselor might be able to do some of this treatment, but if you're a teacher, then again, referring out, talking to the parents, talking to a guidance counselor will be really essential. Often a student might be coming to the teacher and saying, my stomach really hurts or my heart's racing, and they might be seeing that they're sweating a lot or having some of the physical symptoms of anxiety. And making that referral to a trained professional is going to be a critical part of this treatment. And so the other part is just helping the person know that they get a real big say in their treatment and they guide the treatment, what order we do with the treatment strategies. And again, asking the person to ask questions really will increase treatment compliance with all the protocol. So here we have our Thermometer, and this is something I use with all my clients, whether it's adult-focused or child-focused. The younger ages tend to appreciate more of the graphics and the pictures. And what we're basically doing here is rating how fearful you feel. So are we 10 out of control ballistic, experiencing the most anxiety we've ever experienced? Or does it feel, just a little uneasy, about a 3? And so it's a really nice tool. For adults, we might use something that's called SUDS. People often laugh and think it sounds like soap, but it stands for Subjective Units of Discomfort. So I'll say, what's your SUDS? It's a really nice, quick, easy read. This is great for parents because a parent can turn to their child, or even a spouse could turn to their partner and say, what's your SUDS? What's your thermometer right now? And the person who's having the panic attack can say, I'm at an 8, I'm at a 9, and you get a sense of how high or low they are and what work you could do to help support or challenge the panic in that moment. So I'm going to go through now and spend a few minutes to go through some relaxation techniques. Tonight, we're going to talk about diaphragmatic breathing, progressive muscle relaxation, meditation, and sensory grounding. And I often like to tell people these tend to be more helpful before or after the panic attack. Again, we're going to teach you tonight that panic is not something necessarily to be afraid of. It's something that might feel uncomfortable, but it's something we don't want you to fear. And so again, the message isn't use your relaxation skills to make the panic go away because you can't handle it. It's saying, listen, if you want to have some tools and learn to feel more in control of your body, then it's really important that you know you can use them. And we always say that these techniques can be more effective when the person is more effectively challenge the catastrophic interpretations of bodily sensations. So it's hard to relax if you remain convinced you're in danger. So that is a big part of the psychoeducation and the cognitive therapy we'll talk about in a little. So let's do a little bit of interactive work now. I know you've been sitting and listening, so thank you for that. So now we'll get a little more involved. So if anyone wants to practice with me, we're going to talk about diaphragmatic breathing. And so I'm going to ask you to put one hand on your belly and another hand on your chest. And I'm going to ask you to take slow, even breaths. And you could pause between breaths and imagine that your stomach is a balloon and you're trying to fill it up as you breathe in and you're emptying the breath on your way out. And so here's the key. If we were in front of me in an audience, I might say, raise your hand if your top hand was moving more. Raise your hand if your bottom hand was moving more. And as you can see from the last line on the slide, your goal is for the bottom hand to move more than the top hand. Again, that's how we breathe from our diaphragm and get more diaphragmatic breathing. We say that, people who are in a band or singers, they know how to do this. And so for the rest of us, we learn how to do this. We learn how to maybe put a kid's book on our belly and make the book go up and down. And it's a nice way to slow the breath down and really get a deep inhalation and exhalation. If you're one of the many adults tonight who had your hand on your chest and said that one was moving more, that's actually very common. And we hear that all the time because as adults, we tend to do more shallow chest breathing. And just by breathing alone, sometimes that could trigger sort of, I can't breathe, I can't get enough air, and it leads to panic itself. So we learn to help slow the breathing down. Next slide we have is our PMR, progressive muscle relaxation. And so if I asked you, relax your hand right now, you probably wouldn't know how to do it. But if I asked you, let's learn to tense and relax. So I want you to take your fist, make a fist your hand, make a fist as tight as you can, hold it for 10 to 20 seconds. So we're doing that now. Feel free to participate with me. I'm making my fist, I'm squeezing it really, really tight. And after 10 seconds, 20 seconds, I'll say let go. And if you're doing that, you're going to feel that your hand is actually quite heavy. And so what we've done is we've taken the tension of the fist and we've relaxed it. And often relaxation feels kind of heavy and we feel like our hand feels like it's almost, very, very relaxed at that point. And we could focus on all the muscle groups while doing this. And again, we could do some diaphragmatic breathing while we're doing this. So we might be squeezing our feet and we might be squeezing our neck and our shoulders. I might ask my clients, where do you get your tension? Where do you store it? A lot of times people say my jaw. So we'll do the same thing. You'll squeeze your jaw for 10 to 20 seconds, and then we'll learn to relax it. And it really does help us very quickly learn to do a nice relaxation technique. PMR is great because, again, we can do all the muscles at once if we learn to do this. What I always emphasize with any of the practices we're talking about tonight is learning to do it in nice, calm times. So don't try to do this during a panic attack. It won't work. And often clients laugh because they say, well, I know how to breathe. This isn't that hard. And yes, of course, we all know how to breathe. But once we try to do it when we're very panicked or anxious, it's not going to work as well. And so I always tell people practice just like the fireman does where he's running, he'll do drills over and over. And the basketball player is going to learn to do layups and dribble up and down the court before the big game. We have to practice. We have to do it in calm times. So during the more stressful times, we're ready to go and we can almost make our relaxation skills automatic. Next, we have some focus on meditation. I also like to call this mindfulness. So meditation is not being free of thoughts or feelings, but responding to them in a more peaceful, effective, and without judgment way. So saying something like, again, these are quotes from clients, it's just a thought. Thoughts can produce feelings that hurt, but can't harm me. Feelings are always temporary. So we're mindful of all the stimuli that's present, but we don't fixate on it necessarily. We don't try to suppress or control our thoughts. We just learn to control our focus. So we become very mindful of what's around us and what we're aware of, but we're not judging or trying to change the thoughts here. And another final relaxation technique I always like to mention is something called sensory grounding. And so the treatment in its pure sense is 3 one-minute exercises or drills that help learn to ground the body. So in a panic attack, someone might say, splash some cold water on your face. And while that's not always practical, sensory grounding is. What I really like about the tools we've talked about is that some may work at some times. If you're giving a presentation like tonight, my breathing exercise would have been helpful before my talk, but sensory grounding would be really helpful right now. And so what is sensory grounding? It would be using your different senses. So one sense is sensory tactile, another sense is vision or looking, and the final one is auditory or hearing. And what we're going to do is take an object, without looking at it for sensory, we're going to describe the features. What does it feel like, size, marks, without naming the object. And so if I have a pen in my hand, I might say just how it feels. It feels kind of light and rubbery and very long and thin, and it gets narrow at the top. And I would do that for 1 minute. I'd move on to my next one. I'd pick an object to look at, and it could be a different object. I might describe the lamp in my office and say that it has, a beige top with a very dark ebony base, and it has a round shape. So I'd be, again, describing what I see here, not what I feel. And finally, auditory. Sitting in a comfortable chair, I become very mindful of the sounds around me, and I might describe them to myself, whether out loud or in my head. I might say I hear a car starting or dog barking, and those are really important to kind of focus on the auditory piece of this. Over time, I often find that people kind of combine them. So they might take that pen and they might say, well, it feels rubbery on the edge, but it also is black and clear in the middle. And so that's okay. I always like, my clients to make it their own, use the relaxation skill and make it your own, but practice it in its pure sense in the beginning, and then kind of combine it and make it work for you. Again, another reminder not to practice during anxious times in the beginning. And again, when you practice in calm times, you'll become a master and more skillful in that. All right, so here we have a fun slide. Be patient and non perfectionistic with relaxation. So here the person saying, I'm finally learning how to relax. Unfortunately, relaxation makes me tense. So if the patient can't relax, quote unquote, this is very useful information. And we just help them get to a place where they're mindful about that and they understand that there's tension there, but we could continue to work on it and figure out another way to intervene. Okay, so let's move into another component of cognitive behavioral therapy, which is a really important part, which is what we call cognitive restructuring or cognitive therapy. And here we have automatic thoughts. So again, this slide, relies a little more on a child, if they're in your office, or a teenager who is having a lot of anxious thoughts. And we would say, let's do some detective thinking. Where if I have an adult in my office, I'm going to call it cognitive therapy. But the language is the same. For a child, I might say something that's a worried thought, and let's replace it with a calm thought. With an adult, I'm going to call it an automatic thought. And we're going to go through a list of distortions in a little bit. And we're going to look at the facts and the history of what they're telling themselves. So again, if they're saying, I'm in danger, I'm having a heart attack, we might say, what are the facts? What does history indicate? Well, I went to my cardiologist and they said my heart's in good condition and I've been medically cleared. And so we're going to rely on the facts. What I like about cognitive restructuring is that it helps a person think more realistically, not positively or negatively, and it helps them be more realistic. Often that's much more positive than the negative of anxiety, but again, it helps us deal with the concern and say, what's going on and how to be more realistic about it. We help them look at, is there a different way to see this event, knowing that thoughts lead to feelings and behaviors, and so how do we perceive this event differently? And we could always answer the what ifs in a stoic and matter-of-fact manner. How do you feel today? A nice feeling chart. Sometimes people can identify their feelings. With adults, I'll give them a feeling vocabulary list because often people say, well, I feel worried, I feel panicked, and they can't really articulate past that. And so there's lots of other words that kind of capture what they're feeling: terrified, anxious, pained. And so it really does improve. By improving a feeling vocabulary, it helps you kind of catch the thinking even better. And so here's a list of cognitive distortions. I'll go through a key that tend to be really key with panic and anxiety, specifically with our panic attacks. And this is a list of things we tell ourselves to make us feel depressed, anxious, guilty, or angry. So we have all or nothing thinking. So it's, again, all or nothing. With a panic attack, it's either I'm dying, I can't handle this, or I'll be fine, or I can't even handle having it. And so it becomes all or nothing. We help a person look at shades of gray there. overgeneralization. I won't go into detail with all the different distortions, but I think it's good to mention. It's a really wonderful list of distortions. And what are distortions? They're exaggerations. So it's simply just saying exaggerations in our thinking. Overgeneralization just means it's a never-ending pattern of defeat. Mental filters when we zoom in on the negative and kind of miss the big picture. Disqualifying the positive is kind of saying, I had a panic attack today, my life is awful, as opposed to saying, I had a panic attack today, but I still went to that place I'm scared of and I still faced my fear. So it's looking at the positive. A really important one next, jumping to conclusions. Often with panic, we make some mind reading. So let me give you an example outside of panic disorder with social anxiety. So the person goes to a party and they say, well, people don't like me, or they think I just said something stupid. So here they're mind reading. And fortune teller errors, predicting that something negative will happen when in fact it hasn't happened yet. Magnification is magnifying your error, minimizing someone else's error. Emotional reasoning, very important distortion that happens with panic and anxiety. And it says, I feel it, therefore it's true. So we could fill in the blank. I feel like I'm in danger, therefore I am. I feel like I can't breathe, therefore I'm in danger. I feel like people don't like me, therefore they don't. And so emotional reasoning, very important to identify and then challenge. Should statements, I should do this. It creates a lot of blame and fear and guilt. Labeling and mislabeling. Instead of saying I messed up or actually made a mistake, it's saying I'm an idiot, I'm a loser. So it becomes who you are versus a behavior that you did. And personalization, again, it's blaming yourself. This list is a wonderful list that's been used in both areas. Final area of CBT treatment tonight is exposure therapy. Here we teach clients to see their fears as a bully that is bossing them around. And we teach a client to boss back. And we boss back by ignoring the bully. Again, in our case, the bully is our anxiety. The bully is our panic. And we ignore that bully and we do the opposite of what he, she, it tells us. For adults, my clients tend to want to call the bully panic, anxiety, a little more of the clinical term. Kids have a lot more fun with this. They call it the pain in the brain. They call it the random monster, meanie pants. So I've had a lot of really fun terms. Panic attack, the panic monster. They'll call it a lot of fun things. And I find that my adolescents, depends, in middle school, they're too cool for that. So they often don't want to do that. High school, they get back into it and they kind of think it's fun again. So again, really important to understand your age group and tailor it towards their needs. Again, fear feels like a roller coaster. We know that the key is face the fear. As you see on the left side of our U-shaped curve here, we're doing something called exposure. Our anxiety is climbing. What we're predicting is panic will peak. And then guess what's on the other side? Kind of like riding a bike, you get to come down the hill. Your anxiety is now decreasing. And something we call habituation, which is the more you do a scary thing, the more you get used to it. And this is how you master your anxiety, by over time facing the fear. Again, very important to say we're going to do it one step at a time. We call that a hierarchy. So we work from easiest to hardest. And the more you do it, the easier it gets. And so what is a specific type of treatment of exposure? It's called exposure response prevention. This is specifically geared towards OCD, Obsessive Compulsive Disorder, but we do use ERP in all of our anxiety treatments, including panic disorder. So again, the goals of exposure are learning that you can deal with uncomfortable emotions, sensations, thoughts, and habituate or desensitize to it. Another goal is to learn to tolerate it, which is so important. We also get to identify areas of skill deficits that we can work on improving, such as distress tolerance. So the question is, why would I do something that makes me feel bad? And the answer is because it helps. We know it works. By facing our fears, we get used to them. And our bodies get used to the uncomfortable sensations and we acclimate to them. So what's more fun than a polar bear plunge, right? So why do we do it? We know it's not going to feel good, but we know it's a goal that people set because they think it's really fun. And we know that maybe not polar bear plunge, but cold pool on a hot summer day, the more you do it, the easier it's going to get. And we know that if you stay in that cold water, your body really will acclimate to it. And it looks like those people there are having a lot of fun jumping into that cold, frigid water. So that's ERP. Now, one really important therapy treatment intervention that I like to use with panic disorder in particular is something we call intraceptive or symptom cue exposure. And so here we're going to have the patient induce panic-like symptoms in session on purpose, and we'll give them some time to recover. And so often my clients hear this, I get the big eyes. Maybe if we were looking at our audience tonight, everyone say, why would I do that? I'm coming so you could treat my panic and take it away. Tonight's presentation is free from panic. And so why would I want to face the panic? And again, we have to fly in the dark. We have to face our fears to come out on the other side. And so some things we'll learn to do is rate on a scale. Here it says on 1 to 10, how intense is the discomfort when we bring it on? How much fear do they feel? And how similar is it to what they're experiencing during a panic attack? And if the person doesn't report significant anxiety, then we want to make sure they're doing the exercise for a certain amount of time. And anything they're saying is a 5 or higher is something we're going to really be paying attention to and we're going to be practicing. And so let's talk about some examples of the symptom cue, the symptom induction. So again, you'll notice as we go through each symptom that in the office, we're going through all these exercises. There's 9 here. And we might tailor some to aim to someone's specific panic symptoms, but it's often important that they try all of them and come up with different ratings based on how they're feeling. So the first one is head shaking. Here they're going to shake their head loosely from side to side for 30 seconds. Again, the symptom that we're targeting and learning to bring on is dizziness and disorientation. And again, the person learns that by doing this symptom cue exposure, that they could bring on a symptom. Well, guess what? It changes the entire relationship to their panic, because remember that a lot of panic attacks happen within panic disorder are unexpected. And so in this case, we're bringing it on purpose, and it gives us the feeling that we could take it away. Another one is head lifting. So here they're placing their head between their legs for 30 seconds, stepping up and down, running. And again, that's getting the heart pumping. We're getting that racing heart feeling, the shortness of breath that often is accompanied with panic attacks. And then we're going to have breath holding. So we're holding your breath for as long as you can, for about 30 to 45 seconds. Whenever you need to let go, we tell the person to do that. And it produces chest tightness, smothering sensation. And you might be listening tonight saying, I'm having panic or anxiety. Thin straw. Again, in the beginning, you might start with a jumbo straw and work down to a thinner straw for 1 minute, holding your nose. And this is going to produce sensations of restricted airflow, smothering feelings. Again, targeting anything the panic brings on. And finally, staring. We already talked about, a symptom cue is that we're going to work from the easiest significant symptoms. So again, a 5 or higher, and move through it. We're going to keep practicing it. After each round, if they need relaxation, they could do that. And we're going to keep practicing at least once a day. The more, the better. Another facing the symptoms form here, the person's going to pick, let's say, spinning on December 5th is the date they pick. And the repetitions, they're doing 4 times a day. And they just rated here the maximum fear. And as you could see, each time they practice the spinning, they become less and less fearful, which is what we showed in that U-shaped curve, excuse me, of habituation. So the fear is actually coming down. And so again, we want to deal with avoidance. We want to make sure we're facing the fears. We want to make sure that you're increasing the time in feared situations and helping them learn to cope effectively. We're going to also help them realize that this is hard work. It's have the confidence and have the, whether it's panic and not being treated or they're going through the treatment protocol, have that empathy for what they're going through. And I love this slide. If all else fails, bribery ain't so bad. We do prefer to call it reinforcement. And again, critical with kids, we'd be using a star chart. We'd be using points to help them practice, all their treatment goals. For adults, hey, we go to work, we get paid. I do think, adults should be reinforcing themselves, giving rewards, and whether that's just time off, a special meal, or whether it's a privilege, whether they could go out and get something they really enjoy or spend time listening to music they love, something that really works, tying into the treatment is going to be really important. I'm a psychologist, so a disclaimer there whenever I talk about medications, because the psychiatrist is the one who usually, or GP is the one doing the medications. With panic disorder, we often see SSRIs, the selective serotonin reuptake inhibitors, as the key medicines. Sometimes some clients do use the benzodiazepines, like a Xanax. They're fast acting, they work in triggered situations if you're getting on a plane. However, they really can interfere with our exposure response prevention therapy because the message is we want you to feel the fear, slow and steady in a hierarchical way, but we want you to feel that and not take it away because of the medicine, which might send the message that you can't handle it or it's dangerous. And so that's something I'll talk with clients about and work with their psychiatrist how to manage the medication so it doesn't undo the treatment. Finally, Master of Your Anxiety and Panic by Barlow and Krask is one of the tried and true, wonderful books out there that help you do if you want to do some more workbook work or further reading. And finally, some great organizations that we have locally, New Jersey Association of Cognitive Behavioral Therapists, OCD New Jersey. I'm on the board of OCD New Jersey. It's a great nonprofit that offers free speeches and a lot of information. There's an annual conference it comes up. And the Association of Behavioral and Cognitive Therapy is another one, and Anxiety and Depression Association of America. And of course, thank you to New Jersey Center for Tourette Syndrome and Associated Disorders for allowing me to talk tonight in this webinar. And I believe we are done. So I'm going to go back. We'll stay on this last slide. And looks like a great amount of time for a Q&A now.
All right. I think we're ready to go. So
Excellent.
I'm going to launch into some things right away. This is a little lengthy, but I think it's so bear with me a little bit. The question's kind of specific, but there's some background to it. Okay.
Okay.
So this has to do with a 6-year-old who was recently involved in a lockdown drill in school. And
Okay.
It required that he be closed up with a large group of other students and teachers in a relatively small space for probably 5 minutes, probably less than that, but approximately 5 minutes. Ever since then, and this happened a couple of months ago, ever since then, he has not only resisted going to school, but he does not want to go on play dates to friends' houses that he previously had enjoyed going to. And he appears to be a little more clingier to his parents. So this has been a problem now through the end of the school year. So these parents, this is being offered by a grandmother, but the family needs to, figure out how to handle this over the summer so that there won't be a repeat of this, and wonder if you have any suggestions about that.
Absolutely. I took some notes as you were talking. And one of the most important things I would say is taking the child to a psychologist or a therapist or a social worker who is skilled with anxiety management to get a thorough assessment. Because again, one important part of my job is never to assume. And so some of the things that came up for me while that explanation was being read is the child afraid of small spaces? Are they having a claustrophobic feeling? Were they overwhelmed by the amount of people in that, the amount of children in that space? Were they actually aware enough at 6 years old to know why they're doing a lockdown, that this is, potentially with an active shooter? Do they have that kind of fear? And so those are all the things I'd want to be assessing. Was it that, like we talked about tonight, that child having a panic attack during this event and he was actually afraid of what his body was doing and thinks now he's in danger if he's ever in that situation again, but more afraid of his own body? So those are some examples, and there could be a lot more. That's not an all-inclusive list. But we'd really want to understand what that child is afraid of and then really tailor it. So if it was more about danger, let's say the lockdown, then we're looking at more of a GAD presentation. And so if he's afraid of his own symptoms, we're looking at more of a panic disorder. And again, really typical, like this grandma's reporting, that the avoidance behavior starts. So now because they want, not knowing, but common sense says, I want short-term relief. And unfortunately, short-term relief leads to avoidance, which leads to long-term suffering. And so hopefully he can find a good therapist who could reverse that for him and help him realize that when we face the fears, we have some short-term distress, but what do we gain? We gain long-term relief, and help him get back to school and play dates and all the things that make him a happy 6-year-old.
Yeah, and over the summer, those opportunities come up, and it seems that he's, just kind of stuck right now. The not to do anything, then and maybe, you know, maybe he gets more comfortable with his friends over the summer, but not to do anything at all, then you could be confronted with that in September then.
Oh, absolutely. And I would say it might even get worse. Not that we want to be negative, but if we don't address it, sometimes people just hope it'll go away. And if the person, you know, doesn't want to start with therapy just yet, they could, you know, the grandma or the family member can talk about the, you know, talk to the child and say, what is it you were afraid of? And really see if they could get a better sense of it. There's a lot of wonderful anxiety workbooks out there. There's a book, How to Talk to Your Anxious Child. And so there's lots of sort of self-help approaches they could do. But again, I might, you know, recommend there an assessment by a licensed therapist.
Okay, thank you.
Sure.
So I have a question in this, the way it's phrased, it sounds like it's coming from a clinician.
Okay.
And the question is, can you explain depersonalization and how to educate client?
Yeah. So one of the things I do with depersonalization in particular is I normalize that as a list of symptoms on this list. So depersonalization, I should mention, can be its own disorder. So I won't go into the details of that tonight because it's could be a whole nother section. But as a symptom itself is just part of a cluster of other symptoms, we see that as when a person just feels sort of out of their body, they feel detached from their body. And again, if it's not primary, like the only symptom they're presenting with, if it's the only symptom they're presenting with, and they say, I just feel out of my body. I gave the example earlier, like a balloon head, that it just feels like my head is floating above my body. But as a list of sort of as a symptom that's along with heart racing, sweating, chills, if it's all part of that, we normalize that and say that's a typical anxiety feeling that happens that makes you just feel kind of out of it. And we help the person learn to sort of bring that on, as we said in Symptom Cue Exposure. So we might actually make them feel depersonalized, but know that they could do that by staring at a spot on the wall for 2 minutes, have that sort of feeling out of it feeling. But again, it feels harmful, but it's really the body's way of trying to be helpful. And it's in that case just not feeling very helpful. A misrepresentation, as we say.
Okay. You mentioned symptom cue exposure, and I actually had a question about that. Someone's asking for some examples of that. Could you talk about that a little bit more?
Absolutely. And so symptom cue exposure, again, is one of the most evidence-based skills that we use for panic disorder in particular. And so a great example is a client I have who I was working with who came in and was having these unexpected panic attacks. And her symptoms, she was an adult in her 30s, and her panic attack symptoms specifically was the heart racing. And she would start sweating and she would have some of that numbness feeling. And so all these symptoms kind of were coming out of the blue, and she felt just totally helpless and started avoiding in her life. So what we did with her was, one example is we actually stood up in our office and we ran in place for 1 minute. And so that would be a great example of symptom cue. So on purpose, we're trying to get our heart racing. And this is always fun when, you know, it sounds like a bunch of elephants are running in the office. So if anyone's in your hallway, they're kind of saying, oh, there must be doing symptom cue in there. And, you know, they hear you get the heart racing. And then after that example, we're kind of doing things like rating the intensity, rating the severity, rating the similarity. So how similar did that heart racing feel in my office to how it feels when they're actually having a panic attack out of the blue? And then we go home and we assign it. So once a day for 1 minute, they're running in place now and bringing the symptom on. So hopefully that gives a little better visualization of what a symptom cue exposure would be. Again, what I would do with a person in my office is take them through all the 9 symptom cue exposures. And then what we're going to do is tailor. We're going to pick out 2 or 3 of the symptoms that really hit for their particular panic attack symptoms, and we're going to practice those. And then we're going to tailor the homework towards those symptoms in particular.
Okay. All right. Thank you. Okay. Another question here. Okay. I'm just trying to encapsulate this a little bit. So we're looking for suggestions on how to deal with panic attacks that sometime come in the form of tics. So we have an individual here who I would say has Tourette.
Okay.
So they come in the form of tics, even if the fear has been overcome. And the explanation is that I had a fear of fire after a real encounter, but I have overcome it, but still have these attacks during drills. So I'm assuming we mean fire drills here.
Okay.
So,
and so are they saying here, let's interpret a little bit that maybe
okay.
that in
Yeah,
this
it's not
case
quite
where,
a question, but it does.
right,
Yeah.
I think what they're saying, we know tics can be certainly come out of, out of the blue, they come on and, have that urge to have the tic. Or there's times where, they're under great stress. Often clients will tell me that to some degree, they could, control or postpone a tic if they're in school, let's say, and they want to wait till they get home, and there might be an increase of tics later on in the day, although it's not a voluntary thing. Like we have something called Tourette's OCD, which crosses over more to a ritual, and so that's a little more with intention, where tics do not have intention. And so again, let me get back to the question. So were they saying in that case that maybe stress is bringing on the tic a little more, such as a fire drill?
It would appear that way.
Okay.
Okay, so panic attacks that sometimes come in the form of tics, even if the fear has been overcome. And then he had this encounter with fire.
Yeah.
But
So
he still is bothered by the drill. So I'm
yeah.
assuming from this that this is middle school or high school student.
Okay. And I think in this case, okay. I think in this case, again, it might be an example, where they're feeling a specific triggered panic. And so they're, let's say it's the fire drill. And so it's might fall under, if we're looking for a diagnostic criteria. And again, I always say that the diagnosis is important because it really does guide treatment. So that's why this is important to know what anxiety is presenting and how you treat it. And so it might be more a specific phobia if they're afraid of the fire drill or of dying, or to know that, again, whether different techniques like habit reversal.
That apparently there was a fire in the school, and that real thing when it.
Sure. And what we often say about anxiety is a lot of our fears are based in reality. But what happens exaggerates, it distorts. And so there I'd want to help them with the cognitive therapy trigger of the fire happening again. How do I manage? Did I obviously, I survived this fire and I was taken out safely from the school. And to realize that we want to sort of break that connection with the stressor, and that might help reduce not only the panic attacks, but help, again, lessen the stress that we know can exacerbate some of the tics. Not cause it, but exacerbate it.
Okay. All right. Thank you. Have a question. Can you quickly review sensory grounding?
Absolutely. I'm wondering, should I go back to that slide, or can they see the slide? I know
slides are still up, right,
Kel? Okay.
Oh, no.
No, okay, that's fine.
Okay.
All right, so it's really nice because it's anxiety, and what we want to do is quiet it down, and we want to and we're using hearing. And so with that, we're going to practice in the practice form of taking an object with touch. We're going to take the object. Oftentimes, I'll say to a client, what do you have in your hand? Often they have a cell phone, or they have the seam of their jeans, and we want to help them hold it and touch it and just describe the weight, the texture, the sensation of it. And by focusing, again, away from the physical symptoms, the cognitive symptoms, and the behavioral symptoms of panic and anxiety, we're now focusing on something very concrete and tangible, such as the phone. And so, again, it really does help ground, almost distract. And that's appropriate here in that we're choosing what to focus on. We're choosing where we want our attention. And it's a full-blown panic attack, and they may want to wait. And then the final technique is using hearing, sensory grounding, and to help, bring that back.
Okay, thank you. How do you distinguish between a mental tic, such as TS, and a cognitive distortion from a panic disorder?
Okay, so I think I'm going to make the differentiation in the second one, in that cognitive distortions are thoughts in your head, and so they're your thoughts. They're just exaggerated thoughts. And so in that way, the distortion, again, let's give an example, is all or nothing. So either I get an A or 100 on the test or I fail. There's no in between. And so let me ask that first part of the question again, how that relates to tics.
Yeah, you want me to ask it again?
Yes, please do.
Yeah. How do you distinguish between a mental tics, and in this case, the TS is bracketed, so mental tic, as in TS, and a cognitive distortion from a panic disorder?
And again, yeah.
If you would prefer to, we could post this question to the blog. So I don't want to, come with something that you want to think about a little bit more and you're not ready for. So if you want to pass on it, that will be a question that I can forward to you, and you could ponder it a little bit and then reply in the blog.
Sure. Again, where my thoughts are going with that question is there's so much overlap, because we have the tics as a mental tic, and then we have where again, I guess I'm getting thrown a little, is the cognitive distortion is just sort of an error in our thinking. So it's sort of an extreme way of thinking. And so, I'd almost think often we might get the question, what's the difference between a tic and an obsession? And so in that way, an obsession is an intrusive, distressing thought. And then people often say, okay, then what's the difference between, the tic and the obsession? And then we have an overlap where there's been a lot of research done by Charlie Mansueto and Fred Penzel, where they've now coined the term a Tourettic OCD, a Tourettic obsession. And in that way, it's still more in the OCD family than a tic, but in that way, it's more of a, I have a sensation, I have a feeling, and I have to get the just right feeling, or I have to get a sensory feeling. So it's a little more of a ritual in that way. That's more on purpose. Where, again, if I'm going to swing back to the question, a cognitive distortion is just more of an error in our thinking. And so I would go with that. I would certainly, pontificate more in the blog, so I could go into a little more detail on the tic there.
Okay, I'll be sure to do that.
Great.
Let's see, we've gone a little over. I think I'm going to do one more question.
Okay, great.
This question is about somewhere, I can't tell you now where this was in the presentation, but this question has to do with unmanaged insecurity or shyness. So could that in an adolescent, for example, kind of morph into a social anxiety if it's not managed or it's not paid attention to? Or do you just kind of let that go and see what happens?
So absolutely. What I would say, that's exactly where I was thinking when I heard shyness. Often we kind of lean towards the social anxiety category. But again, sometimes shyness is not a problem. And so that's the first part I would say, is shyness creating any kind of, again, functional impairment or distress. Some people are just introverts and they're very pleased, and they like kind of keeping to themselves, and they don't mind their shyness. It doesn't present as a negative to them. They have one or two close friends. They don't feel the need to be part of a crowd. And again, it doesn't interfere. Where it would become problematic is if the shyness becomes more of a social anxiety. And so it becomes a sort of a negative judgment or fear of negative judgment, and moves into more of, now I'm having panic attacks because I feel so shy, so insecure, so uncomfortable in these social situations, that it's now bringing out more of a disordered response. And then that's something there we'd very much want to help the person with treatment and help them learn to manage the panic attacks they're having in response to a shy or a social anxiety trigger, because treatment would be readily available for that.
Okay, so it is something then you should just watch for as a parent then.
Yes.
To see where that's going.
Exactly. If a child is reporting shyness, again, that might not be a problem. But if it's really limiting their functional ability, what I mean by that is they're not getting involved with activities in school, they're withdrawing, they don't want to go to school, they're having a difficulty making friends, then we definitely might be, again, raising the alarm of concern and saying there's great skills out there. Again, we went through the CBT protocol tonight. And so I hope everyone feels very encouraged that there's great treatment out there and really nice skills that you can learn to manage this, again, feeling of shyness that's now taken over and impairing any kind of behavior or feelings.
Okay, I think we're going to end it here. I'm going to turn the programming back to Kelly. She has a few things she has to wrap up with. Thank you, Dr. Strohl. Really appreciated your presentation, and thank you, everybody, for listening.
Thank you so much.
Oh, you're
Thank you for joining our webinar on Freedom from Panic, Learn to Identify and Manage Panic and Anxiety in Adults. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted on our website. This is our last webinar for the 2018-19 season, and we will be picking up again in September. And look forward to our new list of upcoming webinars for that season. We will announce that fall schedule shortly. This ends tonight's webinar. Thank you, Dr. Strohl, for your presentation, and thank you, everyone, for attending. Good night.